Hi, and welcome to part two of the Intellectual Disabilities and Attention Deficit Hyperactivity Disorder presentation. In part two, we are going to be spending time talking about what is evidence-based assessment. We'll cover what is evidence-based assessment for intellectual disabilities, what's evidence-based assessment for ADHD, and then finally, what is considered evidence-informed assessment, for the combo of the two for ADHD plus co-occurring intellectual disabilities. All right, let's start by going over the diagnostic criteria for an intellectual disability. The onset occurs during the developmental periods, and there needs to be both deficits or impairment in intellectual functioning as well as adaptive functioning. So there are three criteria that need to be met for this diagnosis to be rendered. The first is, as I mentioned, there are deficits in intellectual functioning. Now, in addition to this, the intellectual functioning has to be confirmed by a clinical assessment as well as individualized, standardized intelligence testing. And so it is necessary for this disorder that the person who is assessing has been appropriately trained in how to both administer and interpret standardized intelligence testing. So most typically this is going to be a psychologist, perhaps a neurologist, a neuropsychologist, sometimes folks with advanced educational training have this training, but this is something that is required in order to consider this diagnosis. So for some of us, if we don't have the skill set or the competency in how to administer and interpret standardized intellectual functioning, then we would need to outsource or refer out for this portion of the assessment. So that's the first criteria. The second criteria is that there need to be demonstrated deficits in adaptive functioning. So what I mean by this is that there's limited functioning in one or more areas of daily life. And these areas of daily life include things like communication, social participation, and independent living ability. And that we see this limited functioning across multiple environments. So places such as home, work, school, or in the general community. And then the third criteria is that the onset of this intellectual difficulty or deficit and the onset of the adaptive deficits occurred during the developmental period of time. So really early to mid-childhood. Once this disorder is made, there can be several specifiers that are included. And the specifiers are mild, moderate, severe, and profound. And I do want to make some commentary on this for those of us that have been working in the field for a while. In previous iterations of the DSM, these specifiers were almost entirely dependent upon IQ score. So often an IQ score that was, in the like 55 to 70 range was mild, from the 40 to 55 range was moderate, etc. That is no longer the case. That is not what determines the specifier. The specifier is now determined entirely upon the level of adaptive functioning that the individual is demonstrating across these different domains. So I kind of started talking ahead of my slide, but as I mentioned, the level of severity is based upon the level of adaptive functioning. No longer is it based upon IQ. So thinking of this a different way, in previous iterations of the DSM, the measure of intellectual functioning, the IQ score, was almost entirely what determined both if the criteria were met as well as the level of severity. Now there is more equal weight given to both adaptive functioning and intellectual capacity. And so, yes, a deficit in intellectual functioning has to be demonstrated through the use of that standardized intelligence test, but the level of severity is what is used to make the determination about the level of impairment. Now, the vast majority of folks who are identified as having an intellectual disability fall into the mild severity range. And so I want to talk through some examples of types of impairment or kind of magnitude of impairment in these different conceptual, social, and practical domains that you might see if somebody is classified at the mild level. And part of the reason why I do this is because, again, the vast majority of folks with an ID have a mild severity level, and this is also the vast majority of folks that we're going to see in a typical outpatient setting, in a non-residential setting. So what does this look like, or what does this kind of feel like? So folks that have a kind of mild level of severity, or a mild specifier, conceptually what this looks like in kids is, difficulty learning academic skills. In adults, it may look like limited abstract thinking, difficulty with short-term memory, difficulty with planning things out sequentially or planning things in the future, having a hard time with priority setting, and so that can end up looking like rigidity. So these are all areas that are impaired. In the social domain, someone with a mild specifier or a mild level of severity, what this would look like is immaturity in social relationships or in their social reactions that they have. So they oftentimes behave or present younger than their chronological age. Difficulty reading social cues, particularly when social cues are subtle or not very concrete. And related to that, language and conversation does tend to be more concrete about what is actually happening or kind of unfolding in front of them, as opposed to something more conceptual or abstract. Other examples, difficulty with regulating emotions. And so again, emotional shifts might seem more consistent with somebody that is chronologically younger than the person you're dealing with. And then last, though importantly, kind of a limited understanding and risk of being manipulated. So folks who are kind of easily manipulated or gullible. Lastly, in the practical domain, what someone with a mild level of severity would present as, or likely present as, needing support in things like managing their home, shopping, making medical appointments, preparing food, getting from one place to another, managing their money. They might have difficulty with jobs that require anything more than kind of concrete skills. So jobs that require abstract or conceptual skills and thinking can be difficult for them. They might need help making decisions that are of high importance, like how to seek and consider medical care or making legal decisions. So though many day-to-day activities can absolutely be done and maintained, some other aspects of living are quite difficult for folks. So assessing adaptive functioning is a necessary component whenever making a diagnosis of an intellectual disability. And there are many, many different ways that you can assess adaptive functioning. You can assess this through interviews or conversation with caregivers or other people in the life of the person. You can assess this through conversing with the person or interviewing them on their, areas they struggle with and areas that are of strength. But increasingly our field is relying upon more standardized assessments to help supplement the clinical interviewing that we do. And so I wanted to go over a few tools that can aid or support us in making determinations about how impaired a person's adaptive functioning might be. This list that I'm going to go over here is certainly not an exhaustive list, nor is it a list that I am exclusively endorsing, but rather I wanted to bring your attention to some tools that were designed to measure adaptive functioning and that also have good psychometric data. So when I say good psychometric data, I mean studies have been done using these tools to determine that they're measuring what they intend to measure and that they are going to do this reliably over time. So one of the first tools that I want to review is called the Woodcock-Johnson Scale of Independent Behavior. This is a tool that was developed and is normed or evaluated in folks ranging from as low as age 3 up through 80 years old. It assesses functional independence as well as adaptive functioning across the settings that we mentioned before: home, school, workplace, and community. And there's 3 scales, which include a short form, a full scale, and an early developmental scale. So obviously when you have really young kids, an early developmental scale is more appropriate to use than if you have like a 65-year-old. The full scale is oftentimes really useful when you're very first working with a client, kind of need to establish a baseline and to get a history. But then for ongoing progress monitoring or updates and how their functioning is developing or not developing, the short form can be really useful for the purpose of progress monitoring. Another scale, and probably one of the most well-known and used scales, is the Vineland Adaptive Behavior Scale. This was created and has been normed from birth through 90. It covers 3 domains of functioning: communication, socialization, and daily living, which not coincidentally map directly onto the DSM criteria. There's both a parent or caregiver form as well as a teacher form, which can be really helpful in kids who are school-aged. Another tool that can help us with assessing adaptive functioning is the Diagnostic Adaptive Behavior Scale. It's for ages from ages from 4 to 21. Again, assesses the conceptual, social, and practical domains. And also it helps to provide some cutoff points to consider for diagnosis, which can make this a really helpful tool in determining the type and intensity of supports needed. And then the companion scale that goes along with the Diagnostic Adaptive Behavior Scale is the Supports Intensity Scale. This is developed for later adolescence on to adulthood, and it's really helpful for determining what types of assessment, how much or how intense those supports should be. And it assesses the type of support that's needed, the frequency of support that's needed, and how much daily time is needed to support the individual across a variety of areas. Some other tools to consider, and the reason these are on the next slide is because really, useful tools, but comparatively less research or comparatively weaker psychometric data is the ABLE Adaptive Skills Checklist, the Systematic Adaptive Behavior Characteristics Checklist, the Adaptive Behavior Functional Checklist, and then the Impairment Rating Scale, which has child, adolescent, and adult versions. One thing I want to mention about the Impairment Rating Scale, and I will talk about this later, but this is a really useful tool for assessing the impact of ADHD symptomology on individuals. And it has been well validated in the ADHD population, but it has not yet been validated in the intellectual disabilities population. So that is something I want you to consider. But compared to many of these other scales, which are copyrighted and you have to pay a fee to use, one thing nice about the Impairment Rating Scale is that it is an open resource scale. And in your Canvas module, I actually do have a link to the scale, since it is open resource and free to be used, as well as how to score it. So if you're interested in learning more, that's available for you there. All right, we're going to shift now and continue to talk about assessment, but talk about it specific to the ADHD population. And then last, just as we did before, we'll talk about our special population of folks who have both ADHD and an intellectual disability, and things to consider when making assessment decisions. So one thing I want to lead with when talking about assessment with ADHD is the importance or the necessity of considering and focusing on impairment as the central role of our assessment. The reason I'm leaving off with this is because quite often when it comes to assessing ADHD, there is an overemphasis or an over-reliance on symptom presence. And that absolutely is important, but I fear that kind of primary focus on symptoms overlooks some really important aspects of ADHD and things that we need to consider when we start treatment planning. So I'm going to talk a bit about the importance and the role of impairment as kind of being central to assessment. So first, impairment, that is the problems in daily life functioning, that come from the symptoms themselves and cause deficits in adaptive skills are why the client often comes through our doors, why they're referred. And it's this impairment as opposed to the symptoms themselves that really mediate or explain most of the long-term outcome we see with kids who are diagnosed with ADHD. So that slide I showed previously about how folks kind of broke out into thirds, really it's the impairment or the lack of adaptive skills that contributes much to that outcome. And then lastly, I believe it's what it should be what should I said that in a clumsy way. What should be targeted in treatment? The key domains that are typically most affected for folks with ADHD are peer relationships, family and caregiver functioning, as well as academic or occupational functioning. And so these are the areas that we really should be assessing when we are assessing for impairment or deficits in adaptive functioning. And that really this assessment is the most fundamental aspect of both the initial evaluation and how we determine what the targets of treatment should be, as well as our ongoing assessment or our progress monitoring. And then the last point I want to make is that the elimination of symptoms really should not be the focus of treatment because, one, our treatments don't eliminate these symptoms regardless of what kind of treatment you're talking about. But that when our treatment instead focuses on minimizing the impairment that a kid or an adolescent or an adult is experiencing, as well as strengthening or maximizing their adaptive skills, really that is what should be the goal of treatment. All right. Now, despite my previous slide talking about how important impairment is and how it should play the central role in our assessment, I do recognize the necessity and the need for making an ADHD diagnosis. And so I wanted to talk about some aspects of diagnosis and assessment for ADHD that are important. One is that we really need to gather information from adults or other informants, so a teacher, other caregivers, in the child's natural environment regarding one, the degree to which the child displays these developmentally inappropriate levels of the core symptoms, so of inattention, impulsivity, and hyperactivity, and also the associated impairments. So we want to make sure we are getting this information from the adults in the life of the child and the adolescent. When it comes to adults, we want to also try to strive for getting someone else to give us information as well. And part of the reason for this, why we want to gather information from adults and other informants, and not just the child, adolescent, or adult themselves, is because we know that particularly for folks with ADHD, they tend to be very unreliable reporters of their own behavior or the impact that their symptoms have on their functioning or environment. And we know this from many, many observational studies. So even when directly observing behavior, the person who did the behavior is quite poor at reporting it. And this is something that's we really need to consider with ADHD. So what are some of the ways we can get this information from caregivers or other adults in the life of the kiddo? Well, one is through the use of structured interviews. These could be symptom-based interviews, or they could be what we call, broadband interviews, where we're asking about a range of different problematic behaviors or impairments. But using structured interviews with others versus the self tends to yield more reliable and valid information. Two, using function-based assessments, and I'll talk about what a function-based assessment is in a moment. But then three, using rating scales. And again, these can be symptom-focused rating scales or they can be broadband rating scales. The last point I have here, observations. Depending upon the question that we're asking, sometimes observations can be really useful and sometimes they can be yet less useful. They can give us really rich information, but sometimes not additive information that we can't get from these other three more cost-effective means. And really, we're kind of on the fence about whether, there'll always be individual differences, but at a group level, if observational data adds more than what we can get from these other tools like structured interviews, rating scales, and function-based assessments. Now, as we are assessing ADHD, one thing that's really important to note is that with ADHD, comorbidity or the co-occurrence of another disorder is more the norm than it is the exception. It's kind of the name of the game, if you will. So some of the more common disorders that you'll see co-occurring with ADHD include learning disorders or disabilities, language and communication disorders, conduct disorder, oppositional defiant disorder, anxiety disorder, mood disorder, tics or Tourette's, sensory integration problems. And the final point here is comorbidity important in treatment? In terms of treatment outcome or the class, the type of treatment that one should consider, no, it's not that important. But these comorbidities may result in differences in functional impairments, which means that our treatment targets might be really different across children or across individuals. So it's absolutely something to be considered, but it doesn't mean if it's, ADHD and a mood disorder that we need to do a qualitatively different style of treatment than we would if it was ADHD and a language disorder. So we still are going to be in the same ballpark of treatment, just our treatment targets might vary. And I think I've said this in so many ways, but I'm going to make sure I'm saying it really, really explicitly. Diagnosis is often necessary. It's a needed part of any assessment that we do, but it is not as useful to the client and to the family as a comprehensive functional assessment of the client's impairment in daily life functioning. And so really the goal of assessment is to identify which areas of functioning in which the client is showing impairment are there, and how do we treat those domains. All right, so I want to take a moment and describe in more detail one example of a functional assessment of behavior form. This form that I'm going over here is available for you in your Canvas module if you're interested, and I really encourage you to use it because I find it really, really helpful both in understanding the problem behaviors that the caregiver or even the client themselves are bringing to the table, but then it also so naturally helps to align the treatment that we're doing that it just makes this a really indispensable tool. So at the very top is a box that says define specific behavioral target. This is where you would work with the client or the caregiver of the client directly to really understand how they are identifying and defining the behavioral target. So for example, if they would say, this person's impatient, we all kind of know what that means, but like, what does that look like for the client in their life? So essentially you're wanting to get a specific definition or an operational definition of what it is that the caregiver or the client means when they're saying this particular behavior is of concern and something that we want to target in treatment. Once we have a really clear sense of the behavior to be targeted, we then want to work through the following columns. The first column is the setting event. So we're going to ask questions like, how often does this specific behavioral target, this problem occur, and in what settings? And things that we're looking for are like, does it happen at home? Does it happen at school or in the workplace? Does it happen with peers? Does it happen in other settings? Is there situational or environmental variability? Is it happening more frequently or less frequently in certain situations, or is it happening across the board? Is it happening more intensely with certain, people, like peers, for instance, or less often in certain situations? And it allows us to speculate why that might be. The next column is the antecedent column. Now, I probably wouldn't use the word antecedent all the time with clients or with their caregivers, though sometimes I might. But basically what I'm trying to find out is what's the before? So this problematic behavior is happening. What precedes it? What's happening right before? So are there typical things that occur right before the behavior? So as an example, if you have a child who's having tantrums in the classroom, do we notice that maybe this happens when they're given work? Is that a typical antecedent before the tantrum occurs? That's just one example to give you. Is it usually in response to some type of event, or does it really seem to happen for no identifiable reason? And again, is there variability in the behavior? How often it happens, how severely or intensely it happens across time, across settings, across people? The problem behavior, when was it first noticed and who first noticed it? So at what age or in what grade? Did it kind of ramp up gradually, or did it seem to happen all of a sudden, or has it always been there? Overall, what is the intensity or the severity of the behavior? And then the box right above that is the one I think is absolutely the most important, which is, what is the desired behavior? What would the caregiver or the client prefer happen? So a lot of times people want to get rid of or reduce problematic behaviors, but haven't really thought about like what should happen in its place. What would be a more adaptive behavior, a desirable behavior? And so getting the caregiver or the client to articulate that can be really, really helpful. And what would help to keep that more desirable behavior going? Meaning, what's the maintaining consequence? What would keep that going? Anybody can go to the gym once or can tell the truth once, but what would keep that happening over and over again? I'm going to jump back down to the next column beside problem behavior. So thinking again about the problematic behavior, the behavior that we want to target in treatment, what are the consequences after that behavior occurs? Does it get the child what they want? Does it get them attention? Does it get them a unwanted consequence or a punishment? So what are some of the short-term and long-term consequences that typically follow this behavior once it occurs? And then lastly, along with that caregiver, along with that client, we want to think about, why might this behavior be happening? You know, you learned in a previous lecture about the causes or the functions of behavior, the why a behavior occurs. And so just as a reminder, the four functions of the behavior are to get attention, to avoid or escape something that's aversive or unwanted, to get access to something or to acquire something. Or sometimes we just do things because they feel good. So sometimes that sensory stimulation or just is something that the person enjoys. And so when we think about those four different reasons, what's the most likely reason that is keeping the current problematic or, concerning behavior happening? And then that also is really good information as we think about, well, could we help to kind of align the more desirable behavior with that same type of consequence or the same why? The second page of the functional assessment of behavior, which again is freely available to you, are more kind of qualitative questions. So what effect does the behavior have on the child or the client, as well as those around him or those around her? How much impairment or what degree of disruption is this behavior causing? So no problem at all, definitely doesn't need intervention, to extreme problem, definitely does need intervention. How do the parents or the caregivers feel about the behavior? Do they think this is a behavior that can change? How optimistic are they, or how pessimistic are they? Knowing their kind of sense of the behavior can be really informative when making treatment decisions. What have the caregivers tried to do to modify the consequences, and what have been those results? Have they already tried some different things? And if so, how consistently did they try it? How did the child react? What have been those results? And then any notes that I need to make about what I suspect might be happening or other ideas I have, there's a place to note that as well. Another tool I find really useful in assessing impairment or deficits in adaptive functioning for clients with ADHD is the impairment rating scale. What the impairment rating scale is a Likert-based scale that assesses kind of functionality or the type of problems that a child or adolescent is experiencing um, across these 6 domains. It also allows for the rater, so either the parent or the child, I'm sorry, parent or the teacher, to give a narrative description of why they're making the rating that they are. And so I've had, for example, caregivers indicate that, the relationship with their peers or their sibling is definitely something that needs treatment or special services, and then also be able to give me really helpful contextual detailed information about why they're making the rating as they are. One of the nice things about the IRS, the Impairment Rating Scale, is that it's an open resource tool, meaning it is freely available to the public. And again, it is something that I linked for you and is available in your Canvas module. So one suggestion that I want to bring up to everybody is to consider what is the most efficient method of diagnosis and assessment when we're talking about ADHD. And so much of the slide comes from a review by Pelham, Fabiano, and Mazzetti. Um, though this review is a little dated, it still holds true, and it's about what's the most efficient or evidence-based assessment approach for diagnosing and considering functional impairments with ADHD. So the first suggestion is to use parent and teacher or other informant rating scales. So these could be either symptom-based rating scales like the SNAP, the DVD rating scale, the Vanderbilt, etc., or they can be empirically derived rating scales like the BASC, the Child Behavior Checklist, the Iowa Connors. These are all some examples of those types of rating scales. We then want to focus on functional impairments rather than only DSM symptoms or diagnoses. And so one example of a type of tool that can help us to measure functional impairment is the impairment rating scale. And again, I have this linked to you in your Canvas shell, so you're able to access it and score it for free. We also want to use a variety of behavioral assessments and functional analysis of targeted behaviors to understand how and when and to what degree they're occurring. And that this should really be the basis of a lot of the clinical interviewing that we're doing with caretakers, as it helps to directly drive treatment. And then lastly, we need to monitor and modify treatment based on ongoing functional assessments. So using things like a daily report card, for example, as a way to progress monitor how kids are doing. And we will talk about daily report cards later in our treatment section, but I have also linked to you in your Canvas a workbook on how to set up a daily report card if this is something that you'd like to use in your treatment and your ongoing assessment with kids and families. So we talked earlier and mentioned the concept of diagnostic overshadowing. I mention this because, again, historically, having a diagnosis of an intellectual disability kind of disallowed the co-occurring diagnosis of ADHD. And we know now that both can be made and both are allowable in our current iteration of the DSM. But one thing I do want to point out to you is that for this comorbid diagnosis, for this dual diagnosis of both an intellectual disability and ADHD, the symptoms of ADHD, so the inattention, the hyperactivity, and the impulsivity, these must occur beyond the levels expected of those with ID alone. These are not features of an intellectual disability. They are features of something else, but if, for instance, someone with an intellectual disability has difficulty sustaining attention for a long period of time when the conversation is beyond their capacity, or the content they're learning in school is so far exceeding what their current knowledge base is, that's pretty expected. But if the inattention is occurring even in the context of something they enjoy or in the context of a developmentally appropriate demand that's been put upon them, then we would say, yeah, this is beyond just ID alone. In addition to this, the symptoms need to occur in multiple settings, meaning the symptoms of ADHD need to be present before the age of 12 and also must cause impairment in functioning, in adaptive functioning. So thinking really broadly, not specifically yet about specific assessment tools, but broadly, the kind of type of assessment or the components of an assessment that we would need to consider for an intellectual disability include a measure of cognitive functioning, a measure of their adaptive functioning or their degree of impairment, and a functional assessment for some of their concerning behaviors. We need to get kind of age of onset or ensure that the impairment occurred during the developmental period of time. We should always assess for comorbidity. And then lastly, when designing interventions, knowing what a person prefers to work for, so doing a preference assessment, which I know we haven't talked about here, but we talked about in another lecture, is a really good kind of constellation of assessment tools to use with someone you suspect having an intellectual disability. With someone you suspect having ADHD, we definitely want to assess for ADHD symptom presence as well as the severity of those symptoms. We want to assess for impairment, which is very, very similar to how we would assess for impairment or adaptive functioning if we suspected ID. A functional assessment like the one I just presented to you, again, is a really, really useful tool. Again, we also need to know about age of onset or development, specifically that this is happening during that period of development and before the age of 12. And then we also do want to assess for comorbidity, as it can help to drive some of our treatment goals. So if you look at the assessment protocol for ID, as well as the assessment protocol, I'm saying protocol, but really more my guidance, we see more commonality than difference. And if we would put them both together, is what I'm going to go over on the next slide. And so if we would put these two lists together, really what an ideal or an evidence-informed kind of assessment battery would include the following. A DSM symptom checklist. So we would want to get this from multiple informants, and ideally, if we can, across multiple settings. So maybe asking a caregiver and a teacher. That's a really common tactic. There's a lot of different externalizing symptom checklists out there, like the SNAP or the DBD checklist, the Vanderbilt. No one is really better than the other. They all kind of assess the same thing. We also would want to assess for comorbidity. We might do that in a specific way by looking at symptom checklists when we suspect there's something like anxiety or depression, specifically using something like the revised child and adolescent anxiety and depression scale, or we might use a broadband measure, something like the CBCL or the BASC. We'd want to assess, do a functional assessment, so you could use the tool I just presented to you. You could also use something like an antecedent behavior consequence tool. Any of these will get that type of information. We would need to assess for cognitive functioning. You may need to refer to a psychologist or a neuropsychologist or somebody who has explicit training in how to administer and interpret individualized, standardized measures of IQ, but common ones are like the WISC, the Wechsler Intelligence Scale for Children, or the Stanford-Binet. We'd want to assess adaptive functioning. So examples of tools are like the Vineland, the Impairment Rating Scale. And then last but not least, we'd want to do a preference assessment. So using something like the Choice Assessment Scale. So if you suspect or referred someone that has this dual diagnosis or comorbid diagnosis, or you speculate that both are at play, ID and ADHD, this would be kind of a really, really ideal evidence-informed assessment battery.